Okay, good morning, everyone, and thank you very much for joining us. Welcome to the third edition of our Burns System webinar. This is the one related to emergency response and early care, session 3. So this Burns webinar series is a joint initiative by WHO African Regional Office, and the George Institute for Global Health. And focuses on burns in children, in particular in Africa, which is a critical yet under-recognized public health issue that we are all very passionate about. The objectives of the series as a whole is to highlight the burden of childhood burns in Africa, to share evidence and best practices for burns across the spectrum, from prevention to care to rehabilitation, to identify gaps in prevention and care, promote data-informed policy and action, and to strengthen regional collaboration between actors. So as I've said, this is session 3 of our webinar series. In session 1, we explored the burden of disease in children in Africa. In session 2, we talked about prevention pathways in different parts of the world. And now we are looking at the care continuum, divided into early care and rescue, as well as definitive care and rehabilitation, which will be the subject of next month's webinar. And as you can see, these webinars are leading up to Safety 2026, happening in Cape Town this year, where we will have some extra activities. So the care continuum, we've split it up according to the WHO Emergency Care System framework into 5 parts. That includes events that happen at home, events that happen in the community, the journey through the healthcare system and emergency care, and then definitive care at the facilities. And our speaker panel represents all parts of that continuum. We'd like to introduce to you Bahati Shalina, Dr. Shweta Gidwani, Dr. Jimmy Oseret, Dr. Lee Wallace and Vanessa Naidu, who will be co-presenting, and Dr. Tome Mendez, who are our panelists. And they represent, as I said, different perspectives across that care continuum. Just a bit of housekeeping. Please check your audio-visual settings before we begin. There's a Q&A section at the end, which you can use to post your questions, and we will address them one by one. This session will be recorded and will be shared later on, either in clips or in full on various platforms, and there will be our Q&A at the very end. So without further ado, I'd like to introduce you first to our first speaker, Bahati Shalina, who represents the community voice. Bahati, thank you very much.
Okay. I'm going to share with you the experience I got from the community regarding the burns and how we used to treat the burns in the community. Being in the urban slum area, we get so many cases of burns in children under 5 years. The cause is because we have a small playing space. The parents occupy one room, which serves as a living room at the same time as a kitchen. I can share one scenario. Whereby a baby of 10 months was sleeping in the room, and the mother had gone outside. Then in the room there was a small stool where the mother had put a flask full of milk, and the milk was hot. When the baby woke up, she just pulled the flask, and the whole milk splashed on her body, and she got some burns, and she cried a lot. The mother came running from outside, only to find the baby crying, and even the other neighbors came to come and see what has happened. They started giving the what we may call their first aid. They started suggesting put on urine, put on sugar, put on eggs, put on cooking oil, and put on sand like that. Then we were after that the training. After the training, the project had trained us on how to pull the burns. We went back and talked to the community about how to collect how the the collect first aid, and then we taught them. Then we had to tell them the wrong things they have been putting on the bands. Then we got another scenario after the training whereby a 4 years child got another band. She was just trying to serve porridge and the porridge poured on her hand. So the mother was already trained and she tried to pull the, the, the band. Then after pulling that ban, they had to call me to come and assess the ban. So it was not for referral because it was just a small, it was just a small ban. Then we thank you very much, those people who trained us, because now it is now okay. We can know how to handle the first aid properly. And then we thank you, the people who came around to assist us, to help our people, to teach to sensitize us as VHTs. And that, I think, was very good. We thank you very much we thank you very much. And I say over to you, Dennis. Most people
Thank
don't
you.
know what to do immediately. Over to you,
Thank you very
Dennis.
much. Thank you, Bahati. Thank you so much. You are the most important of our presenters, giving us the community perspective as a village health worker in Kampala, Uganda. Our next presenter is emergency care physician and public health researcher, Shweta Gidwani. Shweta, would you like to share your slides so we can continue?
I start with gratitude. So thank you, Dennis. Thank you, Binta. Thank you to WHO African Region and the Georgia Institute for Global Health for actually putting this this webinar series together and for asking me to speak here. But actually, the biggest gratitude, as Dennis said, is really to Bahati. Bahati, thank you for everything that you do in the communities. And really, your stories crystallize everything that needs to be said about burns care and the emergency care response continuum. So there isn't much more to add apart from crystallizing a few thoughts and reflections from my perspective. So, as Dennis said, I'm an emergency care clinician. I've been doing emergency medicine for 23 years. And while I am privileged to work in a regional burns referral center in the National Health Service in England and hold a number of kind of academic and prestigious positions, that's not really where I started. I started my training working in a public hospital in India where we served the urban slum communities. And I've worked in community hospitals and district general hospitals, and a village hospital that now on the bottom right of your screen actually has a building, but when I worked there was a cow shed with a tin roof and no running water. And I still remain very connected to these communities and those in Uganda, where I'm most closely connected with the communities where through our kind of emergency care, frontline healthcare workers. And so kind of my world oscillates between these positions of privilege and poverty. And it's that frame with which I share some of my reflections, my work, my research, my thinking, when it comes to what happens at the front lines and how best we may as we are coming together here today, think about where we may serve the community and save some lives. So I'm just going to say two things about burns. And Dennis, my slides show fine, or just wanted to check they're advancing okay, and you see the main screen, not the presenter view. Yeah.
Yes.
Great. So I want to offer just two reflections really about burns that actually is very, very specific and important as a reflection from a kind of emergency perspective and an early response care. Burns are not just any injury. But that's because of three main reasons. Burns disproportionately affect the most marginalized communities and the most vulnerable: children, women in these impoverished environments. The other unique feature about burns as an injury is that, unlike other injuries, it happens in a private space. It happens mostly at home. That's where a vast majority of the burns and the injuries happen. And that's quite important to think, because immediately you can understand that the bystander response, the immediate response, has got to come from a different space. And the other aspect about how the burn is happening and where it's happening, it's important to recognize that in this private sphere, there's also a lot of other things that interplay. So while mostly burns are accidental, they may also be and are intermeshed with interpersonal violence, domestic violence. There's a lot of stigma that is associated with burns. There's a lot of guilt in that environment that is associated with burns. So burns as an injury is actually very, very unique and special. And it's quite important to think about that from an emergency and urgent response. So burns are not just injuries, they're actually a complex health emergency. And the other side of that, from a care continuum point of view, is that, like with all acute and immediate response conditions and injuries, you do need early response. But in burns, that is, again, unique and different, because it's not just early. It's as early as possible that really will affect the outcome of a burn. For every minute that a burn continues to be untreated in the correct way, the burn deepens, gets bigger, has a greater chance of getting infected, has greater chance of having a poor outcome. So with burns, it is as early as possible. The other issue with the early response with burns is that, unlike in many other competing public health issues and diseases and illnesses, burns does not have a magic vaccine or medication. It actually requires something very simple, which is equally difficult in these situations, and that is access to clean water for 20 minutes. And so this issue of the simplicity of the response often is its own challenge. And then the final issue with the early response of burn scare is that it's competing with culture, belief, and tradition. And these are really enmeshed in the immediate home environment response of the grandmother, the neighbor, the relative who will come to the immediate response of somebody who's been burnt. And these are not wrong responses. They are just intergenerational belief systems that will definitely be the first response. And this is cross-cultural, and it's we know that in Africa there are a number of studies that show that people would reach out to, as Bharati shared the story, to over 40 different types of immediate traditional response. And it's not ignorance, it's really this sort of deep belief of what one might do to respond in that environment, in that situation, and it's intergenerational. So these are the three elements of an early response that burn care is challenged with. And so really what burns and the sort of treatment, early response to burns treatment, is really about the right care, the right time, and at the right place. And it's that immediacy of it, surrounded by the context in which all of this is happening, along with the socioeconomic determinants and the cultural and belief systems that sort of enmesh this, make burns actually quite a challenge. And it's these two things: the fact that burns are not just any injury, and that you don't need just any response, make burns injury a really important candidate when we think about a system that will be ready to respond to kind of any acute challenge. So what then are our candidate best option solutions? And but Dennis has already alluded to this, and we'll hear a little bit more about that in the later speakers. But there's really three things which, in my view, are the focal points of intervention where we may think about having the greatest impact and the biggest gains. The first is really thinking about the emergency care system and a systems framework for the response to burns, because it is a care continuum and it is about an interconnected system that starts right from the home. And is able to respond in an agile manner depending on the complexity of the burn as the burn evolves. Again, going back to that right place, right time, right kind of care. So thinking about burns from an emergency care systems framework as a response is the first sort of area of focus that I think has the biggest gain. And then if you look at that care continuum and the emergency systems framework from that visual, it's really clear to see that it's peppered with people. The system, whether it be infrastructure and some transport vehicles, largely actually depends on provider capability and community first response provider availability. And having just come back from the World Health Assembly, and everywhere we hear continuously this need to have an emergency ready provider response kind of capacity within the health system. And the WHO's ambitious projections are that we need 7 million emergency-ready providers across that care continuum to make a health system resilient, to make a health system responsive. And so, burns as a single injury is a litmus test to really understanding how responsive and ready a health system is. So if you flip it the other way, if we aren't able to focus and respond to one acute burn regularly and frequently in this kind of environment, the system essentially isn't robust and resilient enough to respond to a big shock, such as a pandemic, such as we're seeing the ongoing crisis with Ebola and other things right now. So the second part of that focal point of most probably impactful intervention, in my perspective, is the provider response. And in order to get that, you actually need to be able to have contextually relevant, appropriate conversations, training, support that has local ownership enmeshed with the WHO emergency care toolkits that reaches a kind of scale. Because going back to the initial points, burns happens in that private environment. It has all of that culture, stigma, and belief systems around it. So we have to actually be engaging with the communities to actually create those solutions which will support that and empower the communities and the providers right from the community first responders all the way through the system. So we know this all, and this is not just sort of some reflections that I'm offering, but WHO resolution after resolution after resolution sort of has said the same thing. And interconnected, people-centered health systems approach saves lives. It is essential for universal healthcare coverage, and that integrated emergency critical operative care continuum, both which is contextual, responsive, and reliable, is fundamentally what is going to have the biggest gains to save lives, and it's particularly true in injuries where that acute provider response and acute response is so necessary. So what does kind of all of that look like, and what is our work and research kind of doing in that space? So we've been involved in Uganda doing a lot of community engagement, and we've had a project called the Cool Burns 20, which has really been around trying to unpick all of these different elements and think about how we take those steps that we've just described forward. So we've concluded a community-led participatory a project where we had where we've actually been able to co-create locally, contextually relevant training content, information presented in a manner that is related to the stories like Bahati's. That this training and this toolkit has really been evolved from the community, from the stories and the reality, situated in the realities in which the burn happens. And then we've seen local ownership now of this, and the idea is to sort of share that, and we've had local ownership of that project with a number of local frontline healthcare societies and communities wanting to scale that up and own it. And they're creating, and this is organic. This isn't funded. This is organic. And I want to kind of give a shout out if they're online. Colleagues like Faith and others who've been involved in the front line to sort of develop these tools. They've been using social media to try and get the messaging out there. So it very much locally owned. It feels real and relevant to the communities. And then the next step really is thinking about how one scales this up. If we do want to be thinking about systems response, and we want to think about acute provider capacity. And that requires three things. It's going to require innovation, it's going to require innovative financing, and it's going to require local ownership. So yeah, I'm not going to take more time because we've got a number of speakers ahead, but essentially for me, thinking about the big gains in emergency care and early response for burns, thinking again about those most affected in the most vulnerable places where the majority of the burn disease lies, and recognizing that majority of the burns actually are ones that don't require big operations, and that actually you can really reduce the morbidity and mortality of burns with simple interventions. It requires three things, and I think it requires building that acute emergency response provider trust within the health system, that whatever that urgent response is required, the system will be there to respond, and that's crucial for building trust within the communities. Training, we know that generally acute provider training saves lives and it's very cost effective. And this is again published data from a number of different sources that comes back to the same sort of roughly same figure of basic community provider response trainings at $7 per life saved, as opposed to several hundred for other candidate interventions like drugs and others. And it requires that system approach, that very interconnected, communicated system that will respond to a single acute event, but also multiple acute events. So it needs to be ready and responsive in all of those settings. And with that, I'm going to say thank you and conclude. And there's a lot more to come with the rest of the speakers, and I really want to appreciate Bahati and for her work that she does, and recognize that there's still a lot more that we need to do in this space. Thank you.
Thank you very much, Shweta. That's an excellent presentation. Our next presenter is Dr. Jimmy Oseret, a researcher from Makerere University School of Public Health. Dr. Oseret, are you able to share your slides?
Thank you, Dennis. Thank you, Dennis.
Thank you.
And thank you to WHO Afro and the George Institute for organizing this webinar on the continuum of care. I will share some key findings on delays, referral practices, and barriers to timely burn care for children under 5. And the findings are from the study that Shweta spoke about, the coal burn study, which was a larger study aimed at improving early response, that is to burns in children under 5. In this study, we conducted a qualitative study that involved 15 in-depth interviews and 8 focus group discussions. This was with the mothers, the caregivers, the fathers, VHTs, and health workers who are involved in one way or another with responding to burns. And we did an analysis to try and understand the care-seeking decisions, try and understand the referral pathways, as well as the barriers that families face before a child can receive appropriate burn care. So we identified delays occurring at 3 levels. Firstly, delays happen at home. That is when caregivers are deciding whether to seek care or not. Then, secondly, we also found delays to occur while trying to physically reach the health facility because of transport and distance challenges. And thirdly, delays also continued within the health system when children are taken to the nearest facilities, especially the fact that these facilities couldn't manage severe burns and required additional referrals. So these delays are interconnected in a way. So a caregiver may initially think that the burn is minor and then attempt home treatment. Actually, one of the participants said that some caregivers initially stay at home, attempting home treatment or underestimating the severity of the burn before seeking professional care. Then, the fact that the child deteriorates at home, that's when they decide to move to a nearby clinic to try and manage this burn. But the clinics they move to don't have the capacity to manage. And so the child is again referred to a specialized facility. Here in Uganda, we have Chirudu National Hospital. So this creates multiple delays before care is received. So we also found out why children do not reach appropriate care in time. And there are some barriers. The first one is financial. Families often lack the money to transport, but also if they go to these nearby facilities, they are unable to afford the consultation fees or even to move the child who's been burned. And in one of the quotes, the participant mentioned that a person does not have money that is going to transport themselves to the hospital. These people don't have money, and then we solicit money, and the child was taken to Chirudo, which is a health facility. So there's that financial barrier, but also many caregivers initially perceive burns as a minor injury that can heal without hospital care. Then also relying on traditional remedies is quite common. Relying on what Bahati shared, relying on oils, toothpaste, which is advice from people around. And we see that these practices are culturally rooted, and these patterns are not only unique to Uganda, but we've also seen them in similar settings like Kenya and Ethiopia, which has implications for improving fast response systems. So in terms of the referral gaps and system inefficiencies, even after a parent or a caregiver decides to seek medical care, we found out that the referral system itself creates additional delays. Participants noted weak coordination between the lower level facilities and the specialized burn center. One of the participants said, if I go to Kisenyi Health Center 4, would they refer me to another facility? And how will I access that other facility? They usually don't want to write those referrals unless one is very badly off. So there is that gap there. in coordination, but also the fears around the health system. Also, they mention inadequate emergency transport, the lack of a system to support emergency transfers. So in terms of community and system level barriers, most of the families live far from the specialized burn unit, and they hinted issues to deal with. It's far from where they are, and also the issue of transport, which is expensive. So what they do, they rely on commercial motorcyclists that we call border borders. These are two-wheelers over ambulances and over private cars that they can't afford. We also see that the road network in these informal settlements is bad. A vehicle cannot navigate around in case of an emergency. Then also the weak referral processes kept on coming up, and these factors further increase uncertainty and delays. By and large, as I conclude, most of the delays are shaped by the decisions that are made or taken at the household, decision to seek care or not to seek, many relying on home remedies until the situation worsens. That increases the layer of delay. Then there is a delay shaped by reaching the facility. Those are the financial challenges. But if I'm to go back to the household decision, we also see many first relying or trying out some of the traditional remedies before they seek care, and then barriers around transport and the weaknesses within the referral systems. Thank you very much, and I'll hand over to Dennis.
Thank you very much, Jimmy, for that excellent presentation. We next have Dr. Vanessa Naidu, who's currently attending WHA and therefore cannot present, but she's left us a recording that we will play for you.
Good morning, everyone. I'm Dr. Vanessa Naidu. I'm a technical officer in emergency and critical care at WHO headquarters in Geneva. Thank you for the opportunity to talk to you on WHO's approach to integrated emergency, critical, and operative care as it applies to injury and burns. Unfortunately, if you're listening to this recording, it means that I haven't been able to join you live because of commitments at the World Health Assembly, which is on right now. Burn and injury care have already received attention at the Assembly. Dr. Heba Al-Sawedi from Egypt received the Director General's Award for Global Health for her work in non-profit organization in the Middle East and Africa on the prevention, treatment and research in trauma and burn injuries and reintegration of survivors. So this work has included those in the Gaza conflict and has managed to impact many people. In addition to that, burn and injuries covered under the ECO resolution on WHO 76.2, which is a resolution that recognizes the interdependence of these services and calls for them to be planned and organized in a coordinated way. Member states in 2024 asked for a global strategy on integrated eco-services and a global action plan. So today they will review the global strategy and comment on it. And if approved, we will go forward with developing that action plan for 2026 to 2035. It's the first plan of this nature in this area of work. So there have been resolutions on strengthening emergency and trauma care before, but nothing for integrated eco-services in this way, and not a global strategy and action plan. So we're looking forward to that. The strategy itself has 6 main strategic objectives. It looks at eco-care governance and financing, and models of care, so how services are organized and where they're delivered, and how patients move through the system, the workforce delivering systems, the service delivery and quality of care, the use of data for quality improvement, and then also the functions of eco-services in humanitarian emergencies. Taking that and trying to move it into impact, into action at country level and at the point of care. We do that through three main pillars. So looking at packages and promoting sound UHC packages for care, designing and monitoring pathways, so looking how patients move through the system, and then improving quality of care. That's quality behind my head there. And we have a number of tools to help countries do that. So we have a service planning, delivery, and implementation platform. So this is a tool that is based on the UHC compendium, and it allows for national planning of services at different levels. So looking at, for example, a health center or a primary healthcare clinic or a hospital or a referral hospital, and looking at either specific conditions. So you could look at diabetes, or you could look at an age group, so the elderly or adolescents or children, or you could look at a specific site, so a hospital, and then plan out the services that are required at that point of care for that condition, and then link those services to the resources required in order to perform them. So in this example, we have injury. There are the different types of injury that you can map out, and if it were mechanical injury and you're looking at laparotomy, you can look at then the healthcare workers who are required to do that, and what are the equipment and medications to do that. So this is a very powerful national planning tool, and it's been used in a number of countries already. In addition to that, we have a pathways tool. So this looks at how the patient journeys through the system for a specific condition. So for injury at the outpatient level or in the community already, what should be done at the point of injury? What services should be available or should come to the patient, or then at the outpatient setting or in the facility setting, looking to identify the barriers to those actions and then find solutions for those. And then moving on to services from the community to the facility. So this is a more clinically focused work at the point of care and first contact access. So in the community, empowering communities as users and providers of care, we have a community first aid response, which teaches general first aid, but then also teaches community bystanders how to activate the system. So it makes the link between the community and either the pre-hospital service or whatever emergency services may be available, teaching a basic approach to both trauma and medical emergencies, and including burns in that toolkit. We also have a new what's called the Integrated Management of Primary and Acute Care. It's an app, so it's a mobile-based app that has algorithms for common conditions seen in primary care. So that includes injury and burns, to walk through providers a step-by-step approach to treatment of those conditions, highlighting emergencies or red flags where additional support may be needed, or where patients may need to be referred to a higher level of care. WHO's pre-hospital toolkit is recently released. It's a complete set of guidance for the setup and management of a pre-hospital system, so that looks at operations, communications and dispatch, medical control, and quality improvement and indicators in the pre-hospital system. And then we also have the clinical component, which is the basic ambulance provider course. So that is to train providers to work in the pre-hospital system, so to understand how pre-hospital care works, but then also perform the clinical care with clinical protocols. There are simple protocols based on previous courses, such as the basic emergency care course, designed to guide you in a stepwise stepwise syndromic fashion. Many might be familiar with the Emergency Care Toolkit, which has been around for a while. This toolkit includes tools such as triage for timely identification of injuries, burns, as well as medical conditions. It has a trauma care checklist and also includes the basic emergency care course, which is a long-standing WHO course which teaches a syndromic approach to emergency, so an ABCD approach, and it's designed for both doctors and nurses and also advanced pre-hospital use. So for burn injury specifically, there are modules that are contained in the updated BEC conflict. The conflict module of the basic emergency care course looks specifically at burns, burn patterns, calculating surface area, and then giving basic emergency care for burns. It also has a section on burn injury and conflict settings for burns from fires or flames and the management of those. Burn care is also featured in the basic critical care course. So two of the main cross-cutting components in that course, which builds on basic emergency care, is sepsis and trauma. And burn care is a cross-cutting condition that comes up in all of those areas. A traumatic condition, it may result in sepsis. And basic critical care teaches an approach to management of that, including fluid resuscitation in more severe burns, and then looking at supportive care throughout admission and treatment, and then also looking at more safety and efficiency features like team communication, handover, safe referral, and transfer. We also have the operative care at the first level hospital, and this will look at more surgical components of burn care and debridement, longer term management through skin grafting and basic procedures that can be performed at the first level hospital. We also work. Our unit also works closely with the rehabilitation program, which also looks at rehabilitation across the continuum of care, from the point of injury from primary care through the facility, specialized units, and back to the community, which is very important in the burn care pathway. And further to that, we have our trauma care registry, which is a module of WHO's clinical registry that is designed to collect data, case-based data on injury, which can be used for system planning and clinical quality improvement. So it's a free platform. It's an Android-based platform that countries or facilities can implement and collect their own data and analyze it and use it for quality improvement. That is linked to our Establishing Quality Improvements program. So that is a quality improvement course for senior clinical providers or senior managers in order to do quality improvement initiatives at the point of care. So if you wanted to initiate, for example, triage or institute a trauma care checklist, the course will help you develop a trauma quality improvement plan for that. To get much of our work done, we rely on partners and collaborations, and for this we've developed what's called the Acute Care Action Network. So this is a group of partners it's a WHO convened network, but partners have come together to implement the ECO resolution. So looking at sharing and learning lessons from each other, networking, but then also supporting of implementation of these WHO tools in different settings. The previous network that worked around injury, known as the Global Alliance for the Care of the Injured, is now associated with the Acute Care Action Network, and we work together to move this work forward. One of the big projects of the Acute Care Action Network, or that has come through the Acute Care Action Network, is called the Acute Care Transformation Initiative through Basic Emergency Care, and that's something we're working on at present. It is a plan to roll out basic emergency care training. So this is the hybrid course available on WHO Academy in conjunction with a shortened in-person version for skills training to be rolled out at 1,000 hospitals in 5 countries in the African region, so in Tanzania, Uganda, Ethiopia, Rwanda, and that is going to be run over the next 3 years. It's funded by the Little Foundation, so it includes it's a country-led implementation in those hospitals associated with a stepped wedge study to evaluate the impact of the basic emergency care course. So we're looking forward to that and looking forward to the results that will come out of that. I'm happy to provide further information on any components that I've spoken about. These resources are all available online, or you can contact us at CSY for more information. Thank you, and all the best for the rest of the webinar.
Thank you, Vanessa. Our next speaker is Dr. Tome Mendes, burn surgeon at Red Cross War Memorial Children's Hospital in Cape Town. Thank you, Tome.
So again, thanks for this opportunity, and thanks to all the presenters ahead of us that set quite a nice context of burns in the continent. So I'm going to be speaking a bit about burns down in South Africa, in Cape Town, and I work in the referral centre burns unit here in Cape Town at Red Cross War Memorial Children's Hospital, and trying to provide a sort of a picture of what we managed to do in our setting and how we got there. It's a bit blurry, unfortunately, but this is our entrance hall, and it's Red Cross Children's Hospital in Cape Town, which is a dedicated hospital for children under the age of 13 that turns 70 years old this year. And we're quite fortunate, and I put this early in the beginning, that we partner with a organization called the Children's Hospital Trust. So although it's a government hospital, we have a lot of private-public partnership that was started a while back. And that's allowed a lot of the things that we're going to discuss in the slide to happen in terms of funding and accountability. And if you look at South Africa, it's quite a big country, and we're down at the very bottom in Cape Town. And there's very limited burns beds or burns facilities, and even these numbers are a bit overestimated. So we end up covering a lot of our neighboring provinces as well as the Western Cape. And the distances are quite significant, and they've put us as far as possible from everyone. So logistically, and talking about referral pathways earlier, it's probably not the wisest to be so far away. But in terms of where the infrastructure is, it's down in Cape Town. So we find our patients coming from very far, and often we struggle with coordinating high-level care in patients that aren't actually from our region. And when do we link with local hospitals, and how do we do that efficiently? And we know that the patients we see in our facility are a very small proportion of inpatients compared to the actual burden of burns injuries that we have in our province. We have about 500 admissions a year, but many of our patients are managed as outpatients, a lot in the regional or secondary hospitals, primary healthcare, and then at home. And you try to have as much impact as you can, but you also have to be realistic with what resources you have. And it's been mentioned in the previous talk about referral pathways and how important it is to standardize this process so that referrals happen in a structured way at a provincial level, so that the patients who need the tertiary services can get to us, and the ones who can be managed at base are managed at base with support. We're lucky that this is done at a provincial level already for us, and we're part of that system. Our emergency services relative to other provinces and other countries, I think, is relatively effective at what they do in terms of getting major burns to us as soon as possible. So we might have a delay of a day to two for an acute major burn, but it's very rare that we only get someone 3 weeks post-injury if they needed to come on day one. And like I mentioned, we have clear referral criteria that's been set up. We also, over the years, have built up a protocolized way of managing our burns, and there's an internal Red Cross burns unit protocol that guides junior doctors through to senior how to manage burns in the setting, and that ensures the quality of care is maintained. But most importantly, we know when we're treating a burns patient that they are complex injury with multiple systems and components, and it's not just medical. And over the years, there's been a build-up of the multidisciplinary team around our patients, and that comes with a lot of ongoing input and effort. So from doctors, nursing, ICU, dressing teams, physios, OTs, dietitians, psychiatry, social work, play therapy, and many others, down to the porters that get our patients around, the cleaning staff that helps with the IPC protocols. You really need so many components working well together to provide effective care to a burns patient. And there's many more that aren't even in this diagram. And I think when you're working in isolated or remote settings, one of the hardest things is bringing all of these components together and getting them to work well together so that your patient can benefit. And that takes long and a lot of advocacy to try get that if it's not routine in your hospital. So it was Nurses Day recently, so we have an incredible team of nursing in the ward and in our outpatients that's dedicated just to burns care, with many having been in the system for 30 years and still passionate about what they do every day and guiding sort of the burns care in our service. So yeah, we get about 2,000 referrals a year. Our clinic sees about 4,000 consults, and we are, I mentioned earlier about close to 600 admissions and operations on a yearly basis. In the delayed phase, there's a SCAR clinic overseen by the plastic surgery and the occupational therapy teams, 3 theatre lists a week. We have a relatively low number of beds, 22 beds, for the burden that we see, but I think the utilization of that is quite effective, and we have access to laser on a monthly basis as well. So what does our unit look like? Like I mentioned, we have a 22-bedded unit with 6 high care cubicles where this is separate to ICU. ICU is a separate area, so we wouldn't ventilate, but it's a dedicated burns unit that was built about 15 years ago as a public-private funding project. So we're very fortunate to have it. There's a procedure room and a separate dressing room where the wounds can be washed and head-to-toe washes are done with every dressing change, and led by the nursing team. And one of the most unique things is that within the burns ward, there's a shared therapy space that's primarily between physiotherapy and occupational therapy, where the burns patients can get direct access to this within the ward and not have to travel around and be exposed to the rest of the hospital. And we have a physiotherapy and OT allocated to the burns team that sees every single patient most days. And this is a space where the children can receive their rehabilitation while still acute inpatients, because that is part of the acute care of burns and not something that can be done separately to the acute surgical or medical care of the burns. They're part of our team, and they contribute greatly to the outcomes of our patients acutely and in the rehab phase. And then if you look at our theatre, there's a dedicated burns theatre, again, part of the fundraising and public-private. No one else wants to use it other than the burns team because it's hot. It's at about 30 to 40 degrees. And we have a antique central bed there, which was adjusted, and it's been working for the last 30 years because it keeps working. And it's a basic bed that just allows us to wash the patients with each theatre visit. And it's manual, so it never breaks down with the heat and the humidity. In the corner, there's also a splint bath. And with each case that goes to theatre, the therapy team is there to ensure that they can see the wounds and, if needed, splint on table or sort of plan their interventions while the patient's asleep. So that's very unique And we're fortunate that we have equipment dedicated to the burns team, from dermatomes, skin meshes, and obviously more complex things like the VersaJets and Meek, which we use for our bigger burns. But most of our cases are done using this Humvee knife and a wick blade, and very tired skin meshes and dermatomes, which do break down and have to be adjusted and repaired and replaced regularly. It's a high intensity theatre environment. Everyone loves to ask about the spray on skins and the novel things that you see in international literature. We don't use this, it's too expensive, and we haven't had good outcomes with it previously. And it's just not reasonable in our setting to use this based on the resources we have. But what we do have is the Meek micrografting, which we use for our biggest surface area burns at a high cost and with lots of intervention. But this is our salvage strategy for bigger burns. What else has changed over the last years? We've digitized quite a bit. All of our referrals are done on an app now. It's a standardized app called Vula, where photos are sent with the referral from the base hospital, so that before they send the patient, we can assess the wounds, provide advice, and decide if they need to come to us, if they can be managed at their base facility with support. It also ensures that the right treatment is given at the base hospital before the patient is referred, including the washing and initial first aid, so that doesn't get delayed. When they get to us, we've started a database or registry based on REDCap, where we capture our admissions and op notes and complications. And our wound care is also done using a Android or Apple device with an app that's free to access to healthcare providers in South Africa, which allows us to store photos and see what's happening with the wounds. And that's really changed a lot of the way we can plan our service, how we can advocate for things when we're short-staffed or equipment is failing, and we can give these numbers to our regional managers and use it to advocate for better care and equipment for our patients. In our country, we also have a active burn society that is sort of continuously trying to update the protocols for the region and engage with burns practitioners, because it's a very small community of people doing burns that you often feel isolated, and having a regional burn society really adds support to anyone who's doing burns care alone. And where do we want to go from now? I think, a database or registry is so important, although it's difficult to set up, but it allows you to advocate at your hospital level, at your provincial and national level, or even at an international level when you're looking for funding or grants or support. We're working on improving our outreach and upskilling our peripheral areas, because although we're working in a very good unit, our resources are very constrained still. We always say that we're a high resource hospital in a very low resource setting in South Africa. We also want to work on more regionally appropriate research and protocols so that we are less reliant on international research, which doesn't always apply to the African context or the South African context. And how do we adjust what we're reading overseas to our context? And like I mentioned, prevention and advocacy is a huge part of the work we do when we have capacity for it, because we're so swamped with clinical work. But we partner with groups like ChildSafe, who I think presented in one of your previous sessions, to help promote prevention. And in future, you really want to increase the amount of accredited burns training or fellowship opportunities, because in most areas, it's really not seen as a specialty on its own. It's added to plastic, general, or pediatric surgery, but there's very few areas that actually train dedicated burn surgeons in South Africa and overseas. So I always like to use a farming analogy in terms of, when you're preparing for grafting and how you get conditions right to ensure good outcomes. And what we'd love to see is, these beautiful, if you're looking at farmlands, well looked after fields and, perfect conditions for wound care and looking after patients. And if you read international research, it's even more intense and it's more pristine and it looks incredible on paper. But the reality is in our context, we're often dealing with harsher environments, lower resource, and setting the expectation of what we can do in our context has to be adjusted to where you work. You can't, although we aim for international standards, sometimes aiming for that you might fall short, as opposed to optimizing your resources to your conditions so that you can deliver better care. And that's where the locally appropriate research and protocols are so important, because this is more like a realistic picture where you've got small scale utilization of your resource to provide what you need in your area, as opposed to aiming always for the international data, which isn't always so relevant to us, if that makes sense. So that's my time, and thanks again to everyone for putting this together. It's really an important topic and platform to discuss it.
Thank you very, very much, Tome, for that excellent presentation on definitive care for burns in Cape Town. We're now going to move on to our moderated discussion part of this session, and that will be run by Binta Sako from WHO African Regional Office. Thank you, Binta.
So it's my pleasure to begin with this session, and I would like to invite back all the panelists. So we have Dr. Gidwani, Dr. Osiret, please come in, Dr. Mendez, and Bihati. If you can put on your camera so that we can have some, we can believe that we're in the same room, although it's virtual. I think it's always nice. So for those who can open their videos, it's great. I'll be asking a few questions to all the panelists, and then we'll see also in the Q&A whether we have some questions that haven't been responded. So please, participants, if you would like, you can put in some questions in the Q&A. We are in a webinar mode, so we cannot unmute the participants, only the panelists can speak. So welcome back. And thank you very much for all your great presentations. I'd like to begin with Bahati. Can you unmute? Just to make sure that you can all unmute yourselves. Bahati, thank you very much for sharing with us, a very concrete example of what it is to experience a burn in a community. And I'd like to ask you because you gave us this scenario, but I wanted to go a little bit deeper into what do you think are, as caregivers, what are the biggest challenges in the context that you described? What are the biggest challenges that caregivers or parents face in those first moments when a child is burned, when they're faced with this? What are the key challenges that they face? Can you give us a few cues on that from your lived experience? I think there's a problem with I'm going to ask to unmute. You should receive a message to unmute, Bahati. Yeah. Yes. Now you're unmuted. Go ahead.
Okay. Yes. Immediately the child gets a burn. There is a confusion there in our community. The parent is confused, doesn't know what to do, panicking. And in that process, of course, she has to seek for advice. And those are the advices people give. Just put on put on the oil, put on the salt, put on such and such. That's when he has to get the worst, I may say the worst first aid a child. Yes. Maybe there is a point which I skipped. The reason why we have so many cases is that because in our community we have small brains place, and the parents, we have only one room whereby it is a sitting room and it is a kitchen. So the accident or the burn is likely to occur anytime. Yes.
Okay, thank
Have
you.
I
So
answered
really,
your question?
yes, you have. Yes, you have. And I think this brings us back to the social determinants. And I think, Shweta, you also insisted on this. Burns is not only a technical medical issue, it's really much broader. And you talked about complexity while it's also simple. You know, you juxtapose those two elements. So, what do you think is needed to change some of the community behaviors around burns and also, you know, how can we use some technologies as well or tools to make sure that communities are able to respond quickly? You talked about that, you know, having a quick response and all the other elements that are needed as well. Can you just elaborate a little bit on that?
Yeah, sure. Thanks for the question. It's a great one. Like, I think there's two elements. I think the first part we have understood well and do well, which is participatory co-design, co-ownership, doing that really well in kind of like these controlled studies and research settings and in projects, and we know that that is important, and we situate that learning, and that needs to carry on, and it's a continuous process. So there's more work that needs to be done clearly, but there is a next step that. I think is required to make that leap change, and that requires an element of scale. You do need to be able to have that sufficient reach, if you want to be able to reach the tipping point of a change in behavior. So it's both of those elements. I think we do the first part really well. We have an opportunity at hand, I think, with regards to scale. We're in a real sort of digital innovation space. There's a lot of mobile phone penetration in Africa. We know that that's how everybody interacts with messaging, public health messaging at scale. And so the question is, how do we use the opportunity at hand, the investment that is happening kind of to create that digital infrastructure network across Africa, and then to leverage that with low cost, low resource and innovative financing models to actually reach that scale. So I think it's a great opportunity and a great moment and time. I think that for me is like a really big kind of area of learning and an opportunity for us to sort of consolidate some work and research, because it's also very translatable. Because if we take burns as an indicator problem, and we test out some of these opportunities, we have the opportunity again to diffuse that learning across that sort of acute care provider spectrum for other indicator acute and emergent illnesses and injuries.
Thank you. I may come back to you afterwards. Jimmy, I just want to, you highlighted the different delays, and the delays are from the household to the health system. You pointed out the referral pathways and the failures there, and I think Dr. Tome also did that. And I wanted to know if you could advise a Ministry of Health that we want to strengthen burns referral systems, considering the limited resources, where would you start? Where do you think we have, it's easier to gain time through those referral pathways?
Thank you for that question. So we need to focus on interventions that have the greatest impact. And since we notice there's a delay at household level, we should have targeted community education. And this education should give information to the parents, to the carers on the appropriate response following a ban. Things like cooling the burn, things like remove the child away from the source of the danger and refer. That is one. Then secondly, we also noticed delays along the referral pathway. Caregivers often go to the nearest clinic, which doesn't have the capacity to do so, and time is lost at that level. So I think we need to strengthen triage and early recognition of when to refer, come up with protocols at the lower level facilities, and I do believe this is critical. Thank you, and over to you.
Thank you very much for highlighting this. And I see here in your description also the gap in terms of workforce. And Shweta, you did mention the gap in terms of trained workforce, and you talked about 7 million. Is it 7 million gap? And how do we?
Yeah, so the WHO gap is actually 11 million by 2030 is the projected workforce gap, but the ambition is to have 7 million emergency ready providers. So this is two different WHO documents, so we've got to find a way to triangulate that piece.
Yes, but it is a huge number, numbers that we don't have, and from what I'm understanding, they're also a very important, element to make sure that the quality is at a certain standard and that there's availability. You talked about trust and knowing that when something happens, the community can rely on the health system. And so I just wanted to know if you had any insights into this, because in your presentation you talked about the uniqueness of burns, but also the frameworks, and like we didn't have a chance to have the presentation from WHO that talks about the system strengthening. So how, as countries, do we strengthen burns? Do we integrate it totally into the system? Do we try to go with standalone services? What's your take on this?
Yeah, I think it's a great question. And I think, it's clear that actually we need to take a horizontal approach. Burns is an indicator kind of disease or injury for which we may try to test out and figure out what solutions work. But if it works for one burn all the time consistently from home right the way up, and regularly in the most difficult environments, it is going to work for a road traffic accident, for somebody falling from a height, for a child, etc. And that is the lens with which we need to be operating from a kind of horizontal framework. I think we are, it's clear we're in a situation at this moment in time in global health everywhere where it's clear that we need to coalesce kind of our thinking and our working and our resources in a manner that's actually going to be much more sort of horizontal in its framework rather than we are going to, have one intervention. So, that would be the way I would say that we can utilize the approach. And burns is the hardest one. So if we focus on that and we try to figure that out in these different things, recognizing that broader frame, we may have, a lot to gain from that.
Yeah, thanks. So it's a common denominator that will help for the whole system.
It's a litmus test. If we get it right for burns, we're then much more ready as a system to be prepared for the next Ebola outbreak, which is happening right now, or the next pandemic, or whatever the next crisis is.
That's a very strong, powerful message for the burns community here. So I'd like now to turn to Dr. Tome Mendez. I hope I'm pronouncing your name right. You shared the high quality burns care in South Africa. I think it's a great example for all the countries on the continent, really. And I would like to know, and I'm sure participants here would like to hear from you, what are the key ingredients? Because of course we don't build such a center overnight. So what do you think are the key ingredients? And if you had to advise other countries, how would you advise them to go about it?
Yeah, I think that's always the hardest part. I started in a working system that generations before me have been fighting and advocating for to get it to this point. So I can sort of show an endpoint of a lot of years of dedication and hard work and advocacy. But how do you get there? Probably the biggest thing is you have to be very stubborn, I think, and very patient and dedicated. You need a group of people who just keep asking the questions, just keep fighting for additional support in your area. So if you look at the Red Cross system, there's some famous names in the burns world that, such as like Prof. Roda, Rue Martinez, Gary Dos Passos before me, who have just fought and built the unit over years, fighting with hospital managers for a dedicated ward where there never was one, fighting for theatre time, advocating. And at the moment, what I think, if you're starting from afresh, you need to build your community that's going to do that with you, and start gathering your numbers, because without data, without information, without knowing what the burden is and the impact of not doing something, it's hard to advocate for people to change what they're doing. In our setting, what probably makes the biggest difference to maintaining the service currently is having an effective public-private partnership where we rely on more than one income stream. So it's a government hospital serving unpaid patients, but it has a big charity trust linked to it with accountability. And they've got a track record and they screen the projects, because you're going to struggle to get the resources and ongoing if you don't have that sort of support, I think. But our governments won't want to change or add services unless you have the numbers and the patience to just keep asking and escalating, and not just accepting what you have as the norm. Even with us, we a high-level center for our context, but compared to overseas, we've still got lots of areas to improve, and we're still fighting to make changes and evolve and update. But yeah, it's hard. I think you need to have a lot of commitment and patience.
Thank you. So I take from you need persistence and passion and a good financial model. So those are
it's a high resource.
Yeah.
To manage burns is unfortunately a high resource investment. Yeah.
Yes, but you mentioned that we can also optimize the available resources.
Yeah.
So not necessarily look at the best examples, but look at what we can do with our means.
Yeah.
So that was a powerful message as well in your presentation. I'm going to try to take a few questions from the Q&A. There are a few questions here. I have a question.
I see the first one for me, so
Yes.
I can maybe just continue. And I see the question is around BTM in a low resource setting and in an under-resourced sort of setting with one unit covering 50 million. So we do use BTM occasionally, but more in the reconstructive phase with the plastic surgery team when they're doing contracture releases and the recons. We're not using it much in the acute setting unless there's select cases where we do, but it's incredibly expensive. Unless you have it donated or if you have a preferential pricing agreement, which is another way of fighting for burns cares, fighting the companies and saying we need donation or try get the prices down. But we hardly use BTM in the acute phase. We do use cadaver skin though, so we've got not the cryopreserved, but the other one that's locally sourced. But at the moment, our tissue bank is empty. There's no skin available, so we also face those challenges. And it's a tricky one because, again, BTM is amazing and every research you read is pushing BTM and it's the standard of burns care. But with a few sheets of BTM, with that pricing, you can probably deliver care and resources to another 20 patients. So now you're choosing BTM for the one versus alternate care for 20 other patients. And how do you utilize the cost and how do you justify the cost of not just BTM, but of any high cost item that's pushed to us from the international market over delivering better care to more people, even if you can't save that big burn or that complex burn that needs BTM. These are the very hard decisions with burn skin and low resource setting. It's not whether it's a fixable or repairable wound, but what are the costs of repairing that wound and who suffers as a result in a low resource setting. And they're hard decisions and you need to have a team around you to help you with it.
Thank you very much for that. Another question for Shweta. from Richard?
Yeah, thank you, Richard. If I understand, you asked for some guidelines around community training. So WHO have a number of community provider response toolkits, and the focus of operationalizing Resolution 76.2 is all about upscaling that acute provider community response. So that is the CFAR, Community First Response, Acute Response module. There's a community ambulance response, there's a basic ambulance response, and there's obviously the BEC. That's being rolled out in a number of pilot projects at scale, and there's the push from yesterday or today's sort of passing of the action strategies, a 10-year decade of activity from 26 to 35 to scale up all of those different elements of acute provider response. So in summary, WHO has a lot of toolkits. There needs to be a contextualization of some of that work, which is, very much in keeping with kind of like the WHO kind of mindset. And so things exist, resources are there. There's a huge amount of policy and support. It's about now, triangulating that and getting it done. So very happy to follow up on that conversation with you if there was more interest in that, Richard.
Thank you so much, Shweta. I don't think we have any new questions. Everything's been answered. I hope the panelists have access also to the questions. So I hope I didn't miss anything. But Dennis, do you have any questions to our panelists? Anything that strikes your curiosity?
Yeah, as we know from the burden of disease, that there's a high incident number of cases, but also a high and increasing burden of disease, as well as over the whole care continuum. There are issues from when the burns happen at home through the health system, the community. And so we need to strengthen all parts equally at the same time. It's going to take a lot of money, probably increasingly so as you get farther along the care continuum. And facilities are probably quite expensive to set up and run, as Tome might attest to. Are there any kind of models for low-cost burns management of a high quality in low and middle income countries? Are there, I don't know, Tome, if you in your unit have any mechanisms for, I don't know, for improvising or using low-cost alternatives to some of the treatment methods that you use, and is that something that could be done in other countries?
Yeah, so we are fortunate that we get a lot of support and funding, so we can generally access some of the better dressings, but we are still limited. But I know whenever I speak to my colleagues in the rest of the country or areas that are doing more with less, there are alternate dressings that are sometimes a tenth of the price, and they might not be as effective, but they're 95% there. So that cost reduction, and that's going to change based on where you work. And I think, everyone focuses on the endpoint and the complex dressings and surgeries and burns care. But your need for burns care, your need for surgery is completely dependent on the first aid and the emergency care that's done. And we push quite hard that shifting to that and prevention and is obviously the most important thing you can do. I think everyone agrees on that, and getting the first hospital to up their level a little bit with support. And then we've got one or two local manufacturers that make products in South Africa. We would use them over an international brand if there's equivalent. And you just have to keep asking. And then we don't use much in Red Cross, but I know when you follow these burns groups, a lot of people talk about alternate dressings, the fish skin, the banana leaves, the papaya, and I think and the honey. We use actually a lot of honey, but not the international honey. We use the South African produced honey, which is way cheaper and as effective. And it's not, again, don't get caught up in what the international community is doing. And there's a tendency to laugh off or ignore locally developed protocols. And if someone has seen it work over years and years, although it's not internationally approved, either try do the research or really look locally what you have available, even if it's not mainstream. I'm not saying go and sort of be a cowboy, but don't underestimate what your local resources can deliver with less, if that makes sense.
Thank you. Thank you very much. Thank you very much. We had a little bit more time for the discussion, so very grateful to our panelists. Thank you very much, all of you. Today's session really reminded us that improving burns outcomes begins really long before the patient reaches a specialized facility or even a facility. This is really, burns is really anchored into the social determinants, into the community. And thank you, Bahati, for reminding us of that. It's a everyday struggle for some people. So a few key messages that I got from this whole conversation, the presentations and the discussion is that first, burns care is not only a technical or medical issue. As it's been repeated from the first session to today, it is deeply linked to the community, to the trust, to the behaviors, to the culture, and also to access in healthcare. And community need practical knowledge to address the issue, and they need to have confidence in the health systems. Second, we talked a lot about the delays that occur at multiple levels from the household to the health system, and there's the need for strengthening triage was referred to, the referral coordination, but also the frontline capacity to save lives. A third point that I noted was around the high quality facility that we have in Cape Town around burns, and that it's possible actually to have in our setting, in the African setting, such integrated services that addresses burns holistically. But it takes time, it takes perseverance, and it takes good financial models to support the systems, and not to forget to look at what is possible locally and to learn to do with our means, and not always dream of international standards that will not come, at least not immediately. And finally, through Shweta, although we didn't get the presentation from Vanessa Naidu at WHO, we understand also that burns care must be integrated into broader emergency care strengthening efforts. And there are indeed a lot of tools that have been developed by WHO throughout the years that targets the system, but also supports the community level workers that we can also share with you after this webinar, so that you're aware of all these tools that are available. So as we close this session, we really want to emphasize that survival is only one part of the journey. We presented in the beginning that this was a webinar series that looked at the continuum. So I'm hereby announcing our next webinar, session 4, which is around definitive care and rehabilitation. We hinted at it with the example of the center in Cape Town, but we'll be talking more about the different services that are part and parcel of the burns journey, and around rehabilitation, but also psychosocial support, mental health, etc. And we'll anchor we'll center the webinar around survivorship and the lived experience of burns. The session will be taking place on the 18th of June. And here you have the possibility of scanning if you're new. Otherwise, it is exactly the same link as the previous ones, and you should have it. If you've registered to session 3, you should also have session 4 in your calendar. But if not, please do register. We would like to see many of you as we talk about this entail, but really very central as well to burns care that we will be discussing. So on behalf of the George Institute for Global Health and the World Health Organization Regional Office for Africa and all the partners who've been involved in this webinar series. We'd like to thank you very much for the participation, and we like to apologize for some of the technical glitches that we've had. We'll do better next time. So thank you very much, and see you on the 18th of June for the next session on definitive care and rehabilitation. Thank you very much.
Thank you, Binta. Can I just mention that we do have some resources that are out there for burns at all different parts of the care continuum. So we'll be sending these to people who have registered for this session. And just to draw your attention to the last two, this one here is a community burns first aid training manual that was developed as part of some of the research you've heard about in Uganda. There's also a WHO community first aid response pocket guide that you can use for care at the community level. But there's also guidelines for care across the care continuum that we've talked about. Binta has mentioned the next session, which you can register for here. And then if you could please take some time to give us some feedback on this session and others. There will be a recorded version of this entire talk, including the one that we missed out on, and will be put up on YouTube, on various different platforms for you to look back on and get information. Thank you very much.
Thank you very much. Have a good afternoon.
Thank you. Thank you, everyone.
Thank you.